Imagine a time where the entire public understands and prefers chiropractic, where we treat most of the ills of humanity, where prescriptions are rarely pursued. The path to this more idealized world can only be accomplished with research that demonstrates what chiropractic can and can't do. Research is the pursuit of truth. If the truth be told, our profession will flourish. We need well-designed, fair tests whose results are explained in both the languages of the profession and the public at large. This hour will introduce many aspects of research. The emphasis will be on how doctors in practice can participate in a meaningful and practical way with the goal of personal development and profession-wide progress and expansion. Additionally, we'll have three doctors with both research and practice experience: David Gilkey, Jay Greenstein, and Heidi Havoc. The benefits of chiropractic research have included the profession's ability to gain licensure in all 50 states plus many countries around the world. Research has opened the door to inclusion in various insurance programs, hospitals, the military healthcare, and sports medicine. Research also allows the profession to acquire grants to perform more research. It's easy for someone in practice to feel disconnected from the world of chiropractic research, but incorporating research into your practice can yield you and the profession some tangible benefits. Research isn't a single entity. There are several variations of research designs. Some are applicable to your practice, many clearly are not. Dr. Jay Greenstein has an impressive curriculum vitae. He graduated from National College of Chiropractic in 1992, plus has multiple postgraduate certifications. Aside from a long list of awards and achievements, he has participated as a co-investigator and principal investigator of several research projects, the most recent concerning chiropractic care to reduce opioid use. How you came about having your first participation in a research project?
Well, my first participation in a research project actually started in chiropractic school, where I was fortunate enough to work with Dr. Greg Kramer, who is the chair of the Department of Anatomy at National, and he was running some studies evaluating the use of MRI to image intervertebral foramen. So I was lucky enough to dissect a bunch of lumbar spine cadavers. I still remember that beautiful smell of formaldehyde, never leaves you.
Don't we all?
And measure the IVF in 3 dimensions 3 times for every single IVF that I measured.
And did that first project lead to other opportunities?
Yeah, I mean, indirectly, it led to a lot of opportunities because I was able to publish my first paper, as a chiropractic student. When I was applying for jobs, it looked good on my CV and it caught people's attention. And because of that, I ended up getting a job with Dr. Jan Corwin, who was the Olympic team chiropractor for the 1988 Seoul Olympics.
Here are the various categories of research design, with the top of the pyramid, the randomized control trial, having the most status, and descending to the study designs of the least status. In addition, there are several types of reports. Let's start at the top with the randomized control trial, or RCT. This type of study is considered the gold standard. Many researchers won't discuss anything other than a randomized control trial. Here's what they look like. The trial is designed as to who is included, for how long, what is to be tested, etc. The design is then scrutinized by an IRB, an institution review board. If approved, the trial may proceed. A set of character traits for those allowed into the randomized control trial are precisely stated. These traits are called the inclusion criteria. Examples may be female, age 40 to 60, not taking any corticosteroid medications, and left-handed. Those meeting the inclusion criteria are divided into 2 or more groups. For this example, let's say 1,000 participants are randomly divided into 2 groups of 500 subjects each. One is the experimental or the intervention group. those who will receive the item or procedure being studied. The other 500 subjects are the control group and do not receive the item or procedure. All of the subjects receive a thorough explanation of the trial, the item being tested, the risks, duration, and procedures to be performed, all of the details. This is called informed consent. The subjects must understand that there is a 50% chance that they will be receiving a placebo and a 50% chance of receiving the item being studied. There are variations within the category of randomized controlled trial. There is the randomized, placebo-controlled, double-blind trial. This design title is often used interchangeably with the RCT. This means that there is a control group receiving a placebo and that both the subjects and the research staff do not know who receives the placebo versus the item being tested. Both subjects and staff are blinded. An additional possibility is the randomized, double-blind, placebo-controlled crossover trial. This means that the control group receives the placebo and the intervention group is given the item of study. After 1 year, these are crossed over or switched to where the group that had been given the placebo now receives the item, and the intervention group is now given the placebo. For an individual subject during the 2-year trial, 1 year they receive placebo, and the other year the study item, but they are blinded as to which is which. Or an RCT can compare 2 different treatments given to 2 groups. An example of this was the low back pain trial published in the British Medical Journal in 1990.
This trial was large, 741 subjects, where outcomes of 2 years were reported. The group under chiropractic care improved and maintained their advantage over the group treated by physical therapists. Due to substantially better outcomes in the chiropractic treated group in this RCT, the British government included chiropractic in the national health system. There is a link between research and those in practice.
Dr. Heidi Havoc is the Dean of Research at the New Zealand College of Chiropractic. She is a chiropractor and has a PhD in human neurophysiology from the University of Auckland. She is the author of the book, The Reality Check, runs a company with the mission of enlightening the world about the science of chiropractic, provides an online learning academy, and is one of the most popular chiropractic speakers in the world today. I'm aware of a Swedish study where patients were followed either as maintenance care or just dismissed. And so talk about that a little bit, because that again ties the research world to the practice world.
Yeah, this is Eklund's study, a phenomenal study. That's slightly different again, because we're actually then asking chiropractors to kind of join in a clinical trial, although it's still in practice, which is an interesting concept. So there, you had to agree to either see the patients when they wanted to because they were in pain again, or see them on a regular basis.
All research, including randomized controlled trials, are considered preliminary until they are replicated. However, the important step of peer review and publishing in journals that always include the peer review process lends credibility and validity to the research. David Gilkey, DC, PhD, was in practice for 15 years in California. He is now an associate professor at Montana Technological University. He has authored or co-authored nearly 40 articles in scientific journals and serves on the editorial board for the Journal of Chiropractic Medicine.
Again, the whole concept of peer review is that you actually have been examined and you've done good science, you've done good reporting, and you've extended the knowledge in some direction, so you've added to an existing concept, theory, or practice, or you're taking it another step, or you're challenging it, so that's kind of the perspective you need to have.
Some in our profession have a misinformed idea that research means rats, mazes, and endless statistics, or that research displaces thinking or clinical experience. Not so. The RCT is considered the top of the heap, but these are expensive in time and money and entirely impractical for a doctor in the field. There are other research designs that can also contribute to the body of knowledge. For example, the cohort study. Cohort studies differ from a randomized controlled trial in that there is no intervention. Instead, a group of similar people, a cohort, are selected and observed over time. The item of interest is whether or not this group will develop a given disease or show resistance to disease. Cohort studies are prospective. They look forward in time. The cohort study is different than a case control study, where you define a group of people known to have a given disease and compare them with a similar group known to not have the disease. Then we look back in time, a retrospective study, and compare the two groups in regard to exposures or treatments that are related to the disease. Here are 3 good examples of case control studies.
In the study, symptomatic outcomes and perceived satisfaction levels of chiropractic patients with a primary diagnosis involving acute neck pain, 94 study participants had pain levels improve significantly from their mean of 7.6 on a 1 to 10 pain scale before treatment to 1.9 after treatment. The overall chiropractic patient satisfaction rate was 94%. Clearly, this is an excellent result. Shouldn't all of the primary care physicians in your town be sent a copy of this study?
Here's a second case control study.
In this 2015 JMPT study, they included 403 patients who had seen MDs and 316 patients who had seen DCs as initial providers for their complaints. Patients consulting MDs had significantly less reduction in the pain scores and were significantly less likely to be satisfied with their care. Also, mean costs per patient over 4 months were significantly lower in patients initially consulting DCs. This too is an excellent result. It's important to define the term significant. In the research world, if there is less than a 5% chance of coincidence or some other variable, it is termed statistically significant outcome. This label carries a significant amount of weight.
One last case control study example.
In the study, the association between use of chiropractic care and costs of care among older Medicare patients with chronic low back pain and multiple comorbidities looked at the records of over 72,000 patients in the Medicare system. The study found that multiple comorbidity patients who only use chiropractic care during episodes of low back pain had lower overall costs, shorter episodes, and lower cost per episode day than patients who used other treatments. Another excellent result.
All 3 of these case control studies were published in JMPT, the Journal of Manipulative and Physiological Therapeutics. This is considered by many to be the most prestigious journal in the chiropractic profession. The RCT has 2 or more groups that receive an intervention or placebo. In contrast, both the cohort and case control study designs use observation rather than intervention. Each of these 3 designs are impractical in an office setting. In the next chapter, we'll look at research study designs that can be done in small offices.